right?
Yes, please.
So I would like to introduce Dr. Mohammed Hasan. Dr. Mohammed Hasan he's a Director of Advanced Endoscopy Fellowship at Advanced Health Orlando Center for Interventional Endoscopy. He was trained in Mayo Clinic and MUSC. He's specialized in ESD and boom, and also ERCB, complex pancreatitis-biliary conditions. He's going to talk today about endoscopic management of chronic pancreatitis, treating all the complications. So without further ado, I will ask Dr. Mohammed to start, and happy to have you.
Okay. Thank you so much for the kind introduction. First of all, thanks to Abid and the organizing committee. When this course started in 2014, I was here at that time, and I have been here pretty much every year, except last year I couldn't come, I got sick a day before. But I have seen this progress, really a great progress, where it was started, where it is now, and it makes me really happy. And it's so good to be back. So I'll be talking about endoscopic management of chronic pancreatitis complications. These are my disclosures, none related to this presentation. What is chronic pancreatitis? Chronic pancreatitis is a progressive and irreversible fibroinflammatory disorder of the pancreas. There are diverse etiologies, clinical manifestations, morphologies, and it's not really a disease, it's rather a syndrome, which can present with different clinical manifestations. What I'm going to talk today is mostly chronic pancreatitis and local complications. One of the major complications is the stones. We saw 2 cases today already, and those could be very challenging, could be problematic. Other problems or complications which could happen are the strictures. Strictures in the pancreas, again, because of inflammation and fibrosis. Pancreatic strictures can lead to blockage of the bile duct and leading to biliary strictures. There could be duodenal strictures, and other cumbersome problem could be the leaks. The pancreatic duct leak can lead to ascites, could lead to pseudocysts, pleural effusions, pancreatico-pleural fistulas, but the most debilitating problem is the pain in chronic pancreatitis. All these complications or chronic pancreatitis features can be asymptomatic. Patients may have any or all of the above complications, but may not have any symptoms. But other problems which can happen are the exocrine insufficiency, endocrine insufficiency, but again, the most debilitating problem is the pain. These patients are also at risk of malignancy, and if there are any symptoms suggestive of any concern, they should be evaluated for that, because the symptoms may overlap in these conditions. What are the principles of endoscopic therapy for these complications? Related to chronic pancreatitis, if there is an obstructed duct, stones or stricture, what needs to be done is decompress the duct, treat the ductal hypertension. If there is a leakage, that needs to be bridged with the stent. If there is a stricture, that dilated and be stented. If there is a fluid collection, that need to be drained. And if there is a biliary obstruction, we need to relieve the obstruction. And then comes to pain management. When we provide the treatment for these complications, we hope the pain is going to get better, and there are other endoscopic ways or options to manage pain in such patients. What I'm going to do is I will go through different clinical scenarios for such patients. First, different cases. The first case is few clinical scenarios, 4 clinical scenarios. There may be patients who have a solitary large stone or multiple stones, but without a stricture. They are only in the main pancreatic duct. And other scenario could be stones with the proximal stricture, similar as mentioned above, scenario number 1, but with the stricture. Then there are some patients which have really extensive chronic calcification. And then there is another category which is small duct disease, really not a stone-related disease, but These have recurrent pancreatitis. Young patients have a molecular genetic problem, and that recurrent pancreatitis can lead to chronic pancreatitis. Scenario number one, you see a stone in here. Is there a pointer in this? So I don't know if it's going to work. Anyway, so stone here, you can see in the duct that white spot right there. That's the only stone, obstructing stone there. If you do a ERCP on these, the goal is to get rid of that stone to help with their symptoms. In this case, you can see the ERCP is performed. There is a stone there. Stone, usually when they are more than 5 millimeter, they need some sort of lithotripsy, be it EHL, be it laser lithotripsy. I showed that earlier in a live case too. So you do a pancreatoscopy. There are different pancreatoscopes available, what we call a cholangioscopes, be it spyglass, be it IMAX, or there are other different scopes available as well. The main difference between EHL and laser therapy is laser, you have to put the laser on the stone. With regard to EHL, you have to be using fluid medium and keep the probe away from the stone 1 to 2 millimeter, because it's mostly a hydro energy which is breaking that stone. Also, you have to be careful when putting a fluid in the pancreas. It's not a liver, which can accommodate a lot of fluid. This is a very compressed organ, so you want to make sure that you don't put too much fluid in there and don't puncture one of the side branches. So that's how you take care of that. Mentioned about these pancreatoscopes already. And then next scenario was pancreatic duct stone with stricture. I think hopefully it can play. Can we play that video? Okay. So I'll have to go back every time? Okay.
It's working.
Okay, now it's working. Okay. So this is a case with the pancreatic duct stone and the stricture. When you do a pancreatic cannulation, get the wide end, do a sphincterotomy, do a pancreatic duct dilation, sphincteroplasty, then you may have to dilate the stricture. Then you use laser or EHL to break the stone. And in this particular stone, you can see these stones could be really, really hard stones. I usually tell patients they are as hard as diamonds, but worthless diamonds. And so they really sometimes needs a lot of work. And even after breakage, I was not able to get the wire down on that. So I have to use a Swahendra catheter to get some pathway through that stone, and then eventually place a stent to decompress the duct. And then you can bring these patients back over a few weeks, after a few weeks, to get rid of the rest of the stone. So the steps in this, after cannulation, sphincterotomy, dilate the stricture, break the stone, and then remove as much as you can, and then stent those patients and bring those back. With regard to endoscopic therapy, I kind of pretty much mentioned all those steps. One thing I would stress is when you do mechanical lithotripsy on that, when you're closing a basket, if the stone gets entrapped and the duct is big enough, you really don't need to close the basket and drag it down. If, however, you have to do a mechanical lithotripsy, crush the stone, don't just do quick on crushing that. Do it slowly, let those wires sink into the stone and break it. There could be a problem sometimes, the basket can get impacted. If that happens, then you need an emergency lithotripter, and after that you may have to stent those. When we talk about the pancreatic duct stones, you cannot get away without talking about S-wall or extracorporeal shockwave lithotripsy for pancreatic duct stones. I mentioned earlier as well during the case presentation that for the PD stones, which usually are more than 5 millimeter, between 5 and 10 millimeter. You can do pancreatoscopy, laser or EHL, but some of those end up getting a S-wall. And the stones which are 10 millimeter or more and symptomatic, it's better to send those patients for S-wall first and then attempt a ERCP. Let those stones be broken first before you go in and try to remove those. And then this is another case scenario. Sometimes you see patients like this. The whole pancreas is really full of stones. It just lights up. For these patients, these are different type of stones. You really can't do much except praying for them and also just giving them a symptomatic treatment with the pancreas enzyme supplementation, pain control, and if they're non-diabetic, non-insulin requiring diabetes with C-peptide, they could be considered for islet cell transplantation. This is the scenario number 4. This is a small duct disease, not really a stone disease, and these are usually young patients with recurrent pancreatitis, and they end up getting a total pancreatectomy and islet cell transplantation. With regard to pancreatic duct stones, we know that literature says that these patients which are symptomatic and they're fit for surgery, they should go for surgery. There have been, in this meta-analysis, there were 3 randomized trials, one from 2003, 2007, and there was one from 1993. 2 compared surgery with endoscopy, and the 1 compared surgery with the conservative therapy. Bottom line, what they said is surgical drainage is better than the endoscopy, and patient may have a better quality of life. But neither of those trials used optimal technique for endotherapy, did not target duct stone clearance or stricture resolution with endoscopy, which is the mainstay to improve these patients with endoscopy. Also, patients which were marginal surgical candidates, they were not included in a surgical arm. Another trial, ESCAPE trial, we know that published in 2020, which also compared surgery with endoscopy. Again, they said surgery is better first line for these patients, but in endoscopy group, it was only ERCP with plus minus S-wall, but no pancreatoscopy, no laser, no EHL, and only 40% of the patients achieved ductal clearance. If you look more carefully in subgroup analysis, the patients who had a complete duct clearance by endoscopy, their pain score were similar as were surgery. So select patients which are good candidates for endoscopy may do as good as with endoscopy as good as with the surgery. Surgery in last 3 decades or 2 decades has not much changed. Technique has not much changed. However, endoscopy 2 decades ago or a decade ago was like these old cars, and nowadays endoscopy is like this. So I think it's unfair really to say that every patient should go for surgery. I think we need a new randomized trial with the more aggressive endoscopic therapy to really prove if surgery is better or endoscopy is equivalent to that. And now going further, other complications. PD stones obstruction can lead to pseudocysts. When these are smaller cysts, they may not be drainable transmurally. In those cases, you have to do a ERCP, remove the stone, or dilate the stricture, and put a stent in there. Sometimes these stones in the ventral pancreatic duct can lead to pseudodivism. In this case, as you can see, when the pancreatic duct is injected, it looks like a pancreas divisum, but the stone could be obstructing, and in those cases, dorsal duct opens up and becomes functional. You have to go through the dorsal duct and then again access and treat the stone and stricture as I described before. And then there are pancreatic leaks. A complication could be of a traumatic injury or could be a complication of a chronic pancreatitis. If in this case, you can see there is a collection right in the center and there is a downstream duct and the upstream duct, those are normal. And if you are lucky enough, you may be able to pass a wire through that area of disruption or disconnection and be able to stent that and let the tissue organize around that stent and maintain the continuity of that duct. So there is a difference between disruption, disconnection. Watershed area of the pancreas is close to the neck of the pancreas. Usually disconnection happens in that, like in pancreatic necrosis patients. But pancreatic disruption means there is a leakage, but the duct is not completely disconnected and there is still some continuity of the wall somewhere. And usually in those patients, we can take care of those endoscopically. And this is the end result of that after putting a stent, and then you can see the later pancreaticogram showed a few weeks later healing of that leak. Then there are bigger pseudocysts or fluid collections. Whenever you see a pancreatic ascites, think of a pancreatic leak. Big pseudocyst, think of a pancreatic leak. In these patients particularly, you need to drain these fluid collection pseudocysts transmurally. These LAMPS stents, Axios has made our life better. Usually what we do is drain those cysts or fluid collection transmurally, and then bring the patient back later at some point, do a PD-gram and put a stent in there. That would make it easier. That transmural drainage would make it easier for you to get access to the pancreatic duct. And then there are complications of pleural effusion. There could be a pancreaticopleural fistula. And these are patients really more difficult to manage. You have to do a transmural drainage of these collections, sometimes in the mediastinum as well. Those, do your best to drain those from the stomach. Usually you are very close to the GE junction, but still try to drain from there. Sometimes you have to drain those from the distal esophagus. In that case, use a smaller stent, and if you are using a lumen opposing stent like LAMPS, like Axios, then use a smaller diameter, and then put a larger, longer double pigtail stent in that, and push that pigtail into the stomach so it drains downwards and not cause put the patient at risk of aspiration. These patients also can develop mediastinitis, so I have to be careful about that. And then the last complication which I will discuss is basically about the chronic pancreatitis patients which develop biliary strictures. We do see those patients sometimes, and bottom line in those is either use a multiple plastic stents or use a fully covered metal stent. ASG guidelines which recently published, they prefer a fully covered metal stent because it's more durable and have a better success at resolution. Last thing, pain control. Pain in chronic pancreatitis is multifactorial. There is hypersensitization. There could be a ductal hypertension because of obstruction. There could be a compartment syndrome. Even the nerves become hypertrophic. They lose cells on the surface and become edematous, inflamed. So there are multiple factors which contribute to pain in chronic pancreatitis, different treatment options. And I will just touch a little bit on EUS-guided celiac plexus block and neurolysis. Neurolysis we usually don't do for a benign disease. It's mainly for the pancreatic cancer-related pain, but celiac plexus block, which you can do endoscopically, could be helpful, even though the success could be in only 60% of the cases are solved. By EUS, I won't go through the details of that, but you find out celiac axis takeoff, and then you can inject right above that into the plexus. Sometimes you can find the ganglions, and you can inject local anesthetic like lidocaine, and with the steroid, and there has been evidence, should you do a bilateral, unilateral, in the ganglion, all have a supportive evidence, but at the same time, they all, if they're gonna work, they all really work. Also, look for vital signs. Look at the vital signs, especially the heart rate when you're doing the injection. If the heart rate goes up by more than 15 beats per minute for a minute or minute and a half, that means they have a better chance at success of that block working. We had that with the neurolysis. We have published on that, but that means like you're really in the right place and doing the right job. So take-home points, chronic pancreatitis can present with wide spectrum of complications. If the patient is asymptomatic, you can't make them better than being asymptomatic. So don't need to treat them even with those local complications. If they have a pain, if there is a stone, stricture, try to relieve the obstruction endoscopically. Pain, multidisciplinary approach to that. Older randomized trials, they suggest surgery is superior to ERCP, but I don't think the ERCP with the new technology, the advancement has been given a fair chance. So I think we are in the need of new trials. And these patients usually require integrated care. So with that, I would end. This is the place where I work, and this is our team. So thank you so much.